Great. You know what? Here's what I hope. I hope that a year from now, we're not like all really, really good at these virtual conferences, because I hope that a year from now we are back into face-to-face meetings, shaking hands and talking. I'm grateful that we've got the technology that lets this happen in the middle of a pandemic, but I absolutely miss the aspect of these conferences, which is just meeting people in the hallways in between, having those chats, making those connections that help us kind of maybe feel like we're not alone in the challenges and things that we're facing. But it is great that we can still communicate and collaborate today. So here's what I'm going to do. I've got my presentation up, and I've got it in a way that I can still see the things coming through on the chat window. We've got a little under half an hour here, and I may or may not use the whole thing. Would be happy to take and answer questions along the way if you want to chat them in. I'm saying I can sort of see what's going on here, so if you shoot me a note or if there's a problem with the audio or the video, let me know, and we'll do our best to take care of those. So jumping in. Michael Ames, Senior Director of Healthcare and Life Sciences for SADA. SADA is a Google Cloud consultancy, and my responsibility is to help shape our overall healthcare and life sciences work. Healthcare corporations are our biggest and most important industry vertical, and we've got some great work that we've been doing in a wide variety of ways. But this presentation is less about what SADA is doing and more about some of the experiences that we have had working through this pandemic. What an amazing time! What an amazing time! And I think that we'll look back on this and realize that we have been able to affect some changes in healthcare and the healthcare system that should have been done long ago, and that we will be grateful in the future that got done. And it's tragic that it took a pandemic to get us here. About 5 months ago, I was feeling stressed out by the coronavirus, and late at night, I was up working on something, and I remembered that old Saturday Night Live sketch of the guy who was afraid of the plants in his garden, and he made himself feel better by pasting googly eyes on them. And so I took a few minutes and pasted googly eyes on the coronavirus. It's helped me feel better. As the pandemic has progressed and changed, I've added a little bit to our little guy here just for safety. Now he's got googly eyes and a mask. There is nothing to be afraid of. I want to back up and talk just a little bit about what is different with COVID-19 and the way that viruses and pandemics have been handled in the past. I find comparison between what we're doing today and what happened in the age of polio to be fascinating. So here are a few select dates from the history of polio in the Americas. 1894 is when we first had an epidemic in the United States. Now, this is a disease that we actually think might have been around affecting humanity in different ways for hundreds, possibly thousands of years. There are paintings on the inside of Egyptian tombs showing people with disfigurations that are consistent with our understanding of the effects of polio. But it was 1894 before it started to hit the U.S. really hard. It was 40 years later before we had our first attempt to develop a vaccine. It didn't go well, but the scientific and medical community continued to work on this for almost another 20 years. Jonas Salk, pictured here on the left, is really credited as the guy who had the key breakthroughs in how to develop an effective portfolio vaccine. And that went into large-scale clinical trials in 1954, 60 years after the disease first hit our shores in a big way. Finally, we had clinical trials running in a big enough way to help us understand if this vaccine is going to work. And it wasn't until 1994, just a year before the death of Jonas Salk, that we declared victory over polio, thanks in large part to the vaccine that Dr. Salk helped to develop. 100 years between the introduction of the epidemic and the defeat of the disease with a vaccine. And many, many hundreds of thousands of people affected and had lost their lives during that time. So fast forward now, another 25 years. We have COVID-19 in 2020. Anthony Fauci is maybe holding the same sort of position of scientific moral authority that Dr. Salk did previously in the case of polio. And look at our timelines now. We have our first confirmed case in the US in January. By spring, pharmaceutical companies are running phase 2 trials, with phase 3 trials planned to happen between now and the fall, and an expectation among the general public and our political leaders that we will declare victory over COVID-19 sometime in 2021. And that includes me. I'm watching this play out. This is a big part of my work right now, as we'll discuss, and we see how this is going. And it's, I believe that we're going to be successful. The early signs of these vaccines are looking promising, and there is every reason to believe that throughout next year we will see those vaccines distributed, working effectively, and we'll bring this, at least the acute effects of this disease, to a close. 12 to 24 months, right? 12 to 24 months. Now we can attribute that to a lot of things. Obviously, the work that we did in discovery and learning to treat polio and all of the vaccine work that we've done between them then and now has increased our ability to execute on how we tackle a disease like this. But there is something else, too, that is part of this, which is just the tremendous impatience among members of the public in getting answers to their questions. And somebody highlighted this to me the other day. They said, it is different watching a pandemic play out with a new disease in the age of social media because of this. Because the work of the scientific community is playing out in front of people's eyes. And we have all seen respected scientific leaders who began saying, no, don't worry about masks. They're not all that important. Then pivoting under new information and saying, okay, yes, they are important. And once we were going to social distance in a certain way, and now we're doing it differently. And once the timelines were expected to be around here, and now they're this. And once we were through the first surge, and we believe now if we keep at it, that surge will continue to drop. And now here we are in either a continuation of the first or the second. And it is having the unfortunate effect of reducing the confidence of the public in some quarters in the scientific community. But remember, we're still talking about smashing this disease down and very likely within a period of a couple of years, relative to 100 years for polio. But the difference was the work of the scientific community in those days was taking place within the scientific community. And periodically, when there was a breakthrough discovery, there would be a news article or a presidential speech saying, hey, we're making progress against this disease. And people can say that's great, right? But now what we're seeing is the normal process of discovery playing out in front of people's eyes every day and changing every day what is important about this disease. And that's having the deleterious effect of causing the general public to question the reliability of the scientific process and the medical guidance and the public health guidance that we're receiving. What an interesting insight, right? And it's in parallel with, in general, this massive cultural shift that we've had in the U.S. Honestly, beginning with the introduction of the World Wide Web and being highly increased with the introductions of smartphones in our pockets and 4G internet service everywhere we go, now 5G. People expect their answers now and their solutions now, and they want things to play out in a fast and consistent, direct way to a solution. And that's not the world that we're in. And that has affected, I think, many of us in the healthcare industry in how we have participated in our attempts to respond to the COVID-19 crisis. So one of the ones that I've been responsible for at SADA has been the National Response Portal. Some of you may have heard of it. You are welcome to go out to nationalresponseportal.com, check it out, look at what we're doing. I'm going to be pretty transparent with this group here about what our objectives have been, things that we've accomplished, and some things that we have not accomplished based on perhaps early on not quite understanding the rapidly evolving nature and challenges associated with pandemic response in this age of impatience. So you can go out there and I encourage you to look around what's available. It's free to the public. It's a pure greater good project that we have done in cooperation with Google Cloud and with HCA Healthcare. And you'll see in there some things that you're familiar with, charts and graphs showing case and death rates and rates of increase and other things. Also a few things that we feel are kind of unique, like this chart here on the left that relates together start and end times of social distancing policy with changes in mobility, how much people are spending, how much time people are spending at home versus out in the community, and then changes in the growth of case and death rates. So some things that help us to understand what's going on at the intersection of social policy, mobility, and the spread of the disease. And you can drill down into lots and lots of detail down to the county level and get some insights from this. And we've got a great roadmap ahead for where this is going. A little more detail here, in addition to trying to pull together accurate and complete data on key COVID-19 metrics. We're also working very closely with a couple of organizations on forecasting models that will help to give, we believe, working in conjunction with some really outstanding data scientists and epidemiologists, that we can improve upon some of the models that are out there to help show county level forecasts of what may be coming ahead in terms of cases, deaths, hospital resource utilization, and perhaps most importantly, actually drilling those forecasts down to the hospital facility level, so that organizations who are participating with us by sending data to us that can help to power this portal get back specific insights into what may be coming next for their organization. And again, continued focus on that intersection of public health, social behavior, and health outcomes. And a project here that really began as a service that we were going to provide to the healthcare community, we realized had a tremendous amount of value to the general public, and it's out there. You can go check it out for free today. But here are some things that we didn't anticipate when we launched on this thing. The first is that we developed very quickly hypotheses in the early days about what would matter in terms of data that could help someone to develop insights into what's coming next with respect to this pandemic. And you remember back in January, it was about cases. We were just concerned that people were being diagnosed with this disease and we didn't know what it meant. Unfortunately, shortly after then, we started to see deaths relating to those cases. And now we have another metric that we need to pursue. And the early designs around the National Response Portal were really built around, okay, what can we do with this data in order to help make something useful out of it? We know about cases, we know about deaths, and that's about it. Then we started to understand and anticipate the concerns around things like ICU utilization, ventilator utilization in hospitals, admissions, and this ongoing question of, is the disease spreading because it's spreading or just because we're testing more? Spoiler alert, it's actually spreading, and we can see that in the data around test positivity rates. Start to layer in a greater understanding of how mobility and social distancing might affect this disease, realize that we need it on the individual level, and start contact tracing. We're going to then try to layer in value around public policy, compliance to policy, mask usage, which is a huge deal, the forecast that I talked about, understanding transmission rates, reopening of schools, social determinants of health, the economic impact of the fact that we've shut down the economy. What does that mean for returning to school? And what does it mean later this year when we start to layer on a COVID-19 pandemic on top of the annual influenza cycle? And you can see that we never, ever, ever run out of data that might be useful. Yet we were faced with, in our initial designs that focused primarily on cases and deaths, a system that we built very quickly in order to respond to a crisis that was happening literally that day, and initial case surges that were anticipated to come our way within the first few weeks. And we thought, okay, we know the data that's necessary here. Let's build a system, get the data in, and start working with it. And as the pandemic evolved and changed, and it became apparent that there were new kinds of problems and new ways of looking at those problems, we learned some painful lessons about the importance of agility when you're dealing with something like crisis response. Our view in the early days of the pandemic was a little bit too narrow, and we assumed that those first few key metrics that were going to matter were the metrics that were always going to matter. And we did not put enough effort in the early days into building infrastructure that would allow us to quickly and rapidly evolve to these changes, presenting new views and visualizations that could help to respond to the pressing matter of that moment. And I think that there are lessons in this that apply to pandemic response, but also to apply to how we seek to systematize solutions across the healthcare industry. There are diseases and treatment paths that have been long established, and that we exercise our responsibility best by simply doing things the way that they have been done. But there are so many more things where we need to be able to evolve and to be responsive. And the urgency of the pandemic has brought that into focus. So when we talk about agility from the bottom up, key lessons for us: move fast, but prepare for change. And I would say that one of the aspects of this is keeping an eye on aspects of the problem that you're trying to solve that might pull you into a rabbit hole and distract you from more important issues. So we launched early on with a piece of technology that was central to the overall architecture of this system, but that had not been designed for the kind of scalability and flexibility that would support an application that would be exposed to the general world, or to the general public worldwide. And we built our solution on that from the early assumption that this would be a product that would be viewable primarily by a handful of people within the healthcare industry. And when we realized that this was data and analytics that were needed by the general public, we also then realized that we had built this on technology that was not prepared for the kind of volume of usage that the general public could bring. Further, we exacerbated that problem because in our desire to stick with this technology that was working and comfortable, we ended up spending about a month in trying to make it work, fit this square peg into a round hole, during which time the pandemic was moving on without us. In retrospect, we should have, in those first days, said, here is a solution that is going to work for now, but we anticipate change. And because of that, when we start to see that this part of a solution isn't going to work, we're going to be prepared to pivot quickly out of that and replace it with something else more suited for the need. And we allowed ourselves about 4 weeks of stubbornly holding to the original technology, during which time, again, the pandemic sort of got away from us, and we've had to work to recover that time. Now, happy to report that we ultimately did make that pivot, and our solution now supports millions of concurrent users, and we don't have that challenge any further. But I regret that we didn't catch that earlier and solve that problem sooner. And that also then speaks to the second bullet, which is that if you're building technology solutions, they need to be designed for agility. And there are opportunities with modern technologies that are serverless, that are business focused and solution oriented, meaning that the ratio of time that you have to spend keeping the lights on and keeping something running relative to the time that you spend focusing on solving your business problems is small. And we should have, and we have now pivoted and we have learned to focus on these technologies that are designed in this way that sometimes at the outset might seem like you've got to learn new technology and there's cost there and we don't have time to invest in that. But the reality is we have found that the little bit of effort involved to get past the learning curve has paid off in big ways, as now our ability to pivot, to build in new analytics, integrate new sources of data, and improve our product is rapidly improved. It's a form of sharpening the saw that always pays off. Third, we have been fortunate to have some really fantastic expert sponsorship out of places like HCA Healthcare, CHS, and others who are helping to advise us on the direction of this tool in a way that can benefit as many healthcare organizations and individuals as possible. And we recognize in retrospect now some things that they were hinting to us early on, some messaging that we might have missed. So for example, this question of testing positivity rates, that issue was coming up within this network of experts weeks and weeks before it became a matter of national discussion. And we have learned now to listen to that network of experts and understand that they are seeing enough ahead that with our agility in place, we can build solutions based on the hints from our experts that can be ready by the time it hits the national discussion. And that's our goal. We want the moment that everybody's uncle is arguing about a topic on Facebook to be able to answer those questions with people pointing them to data that they can see in the National Response Portal. And that network of experts is what helps us to get there. Finally, just some thoughts about listening and how that impacts agility. It is often true, especially when dealing with science that is not well understood, that you will learn more from what people are not saying than what they are. We feature a big button on the portal for people to give us feedback, tell us things that aren't working, things that they want to improve upon. And we have yet to receive through that button much by way of critical commentary. And we fully expected it because that's part of how we know that we need to make changes. And we know of problems in the portal and things that need to be improved, and yet we aren't hearing that same feedback from our users. And the issue is that most people, if they see something and they don't like it or it's not quite right or it's not what they need, they will simply move on, especially for a free service that they haven't paid for. So we have learned that to get that kind of feedback on the service that we're providing, it's not enough to wait for people to come and tell us what their issues are. We have to go to them. And so we're beginning to work on processes where we are actively seeking out feedback and response from the users of the portal and from others in the healthcare community to help us to get that early, helpful, constructive, critical feedback so that we can turn that into features and changes and requests that will serve their needs better. But if we don't go ask them for it, we're not going to hear them. So this is an active form of listening, soliciting input, and then incorporating that into a virtuous cycle of changes that hopefully helps us to move now at a rapid rate and to be able to respond quickly and flexibly as this pandemic continues to evolve. And that's what our goal is. So we've got about 5 minutes left. That was all that I had prepared to present to you. Happy to take any questions or comments that you would like. I'll give just a minute in case there are people who are still sort of formulating their thoughts. I don't have a slide on it here, but I certainly want to extend the invitation for those of you who represent hospital systems or healthcare organizations or data aggregators of another kind to go to our homepage at nationalresponseportal.com, go to this For Healthcare Organizations page and read up on how you can participate with us. We are still in need of data and more partners to help us fill out more of the regional gaps in the United States. Our consortium represents about 400 hospital facilities right now across the U.S., but that's, as you know, a small fraction, and we would love to have further participation. Tom Carson is saying, I'd like to understand more how the agility was managed and received. Tom, do you mind expanding on that question just a little bit? In what sense? Or can you give me an example? I guess I'll say this. I shared the slide that showed some of our key healthcare partners, and we have done all of this also in conjunction with Google. And if I were to say anything in our defense of some of these mistakes that we made in the early days, it will be in part that if you think of a collaboration network like that as kind of a web, points with connections in the middle. On the one hand, that web can be very valuable for gathering expertise, working through that network in order to expand your reach and understand where you should go next. But it can also be a little bit constraining. And there are certainly decisions that we may have made differently earlier on if we were operating in a more autonomous and sort of authoritative way. It's another expression of the usual, problem with the democracy versus authoritarianism. Hey, if you've got one tough person in charge, and they can get things done quickly. And it is true that as you build out networks, other organizations with whom you have to coordinate, and you've got people with different visions of what the things should be, that it can make it harder to be agile. And so I would say that if you are the person in the middle of that network, it becomes important that you become very good at articulating the need for agility to those other partners and helping them to understand how decisions that they are making or perspectives they are bringing to bear might be getting in the way of you being fast and flexible like you should. So were I to rewind 4 or 5 months, I would have established early on these things. We don't know where this pandemic is going. We don't know how long it will last. We're building a platform here upon which we may be able to help others. We can only succeed at that if we are prepared to be flexible and to change. So here are the rules of engagement, right? Here's how we're going to make decisions. Here's who's going to be accountable for them. And we are not going to allow ourselves to get sucked into month-long rabbit holes that may inhibit our ability to get this thing done. And that way you can build agility in at the level of your network and collaboration. Thank you, Tom. 7 seconds left. Time is running out. Thank you all for joining.